Welcome to the NCLEX Review, where I help you review all the things you need to know for NCLEX. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com. So we just went over in depth fluid and electrolytes. This is a review that comes in the packet. That was a free study guide that you can also get, so you guys can put them together, whatever you feel like is going to help you. To add on to what we just talked about, we have different types of fluids. So the first type is called intravascular. So this is a fluid inside a blood vessel. And we have intracellular, fluid inside a cell. Mostly bodily fluids are inside a cell. And we have extracellular, so this is fluid outside the cell, which includes interstitial fluid between cells, blood, bone, connective tissue, and water. Then we have different types of solutions. So we have an isotonic solution. These are things like 0.9% normal saline, D5W, and lactated ringers. They have no osmotic force, cells don't swell or shrink. Then we have a hypotonic solution. This is, I like to think of it as lower than our isotonic, so 0.45 normal saline or 0.33 normal saline. And these have a lower concentration of salt, which causes water to enter the cell. We have to watch for edema with these. Then we have hypertonic. So I like to think of these as higher than our isotonics. So this is 3% normal saline, 5% normal saline, D10W, D5W with 1/2 normal saline, D5 lactated ringers, and D5 normal saline. These are more concentrated solutions, so they have more solute than water, and water is removed from the cell, so the cells shrink. Then we have colloid, so this is dextran or albumin. These are plasma expanders. Fluid moves from interstitial to intravascular compartment, and this is given in severe hypovolemia. Patients with severe nausea and vomiting are at risk for electrolyte imbalances. We want to keep that in mind now that we're talking about electrolyte imbalances. So for electrolytes, let's talk potassium imbalance. And we can remember the normal range of potassium, as potassium is found in bananas. So when you buy a bunch of bananas at the store, you have between 3.5 to 5 bananas per bundle. So when we talk about hypo, that means low. So that's going to be anything less than 3.5. And when we talk hyper, that's high. So that's anything greater than 5. And those are our parameters. So what are some things that we are going to see? For hypokalemia cardiovascularly, we're seeing a thready, weak, irregular pulse. Now, if we look over to hyperkalemia, we're actually seeing the same thing. So that really isn't something that we should memorize, because it's not going to be something that differentiates between the two. Now, if you look also cardiovascularly, again, we're seeing a decrease of blood pressure for hyperkalemia, and we're seeing orthostatic hypotension for hypokalemia. Pretty similar. Now, when we talk about respiratory, with hypokalemia, we're seeing shallow, ineffective respirations due to skeletal muscle weakness. When we look at hyper, we're seeing profound weakness of skeletal muscles leading to respiratory failure. Again, these are pretty similar. So let's keep moving on. So neuromuscularly, with hypokalemia, we're seeing anxiety, lethargy, confusion, and coma, skeletal muscle weakness, leg cramps, loss of tactile discrimination, paresthesis, and deep tendon hypoflexia. With hyperkalemia, we're seeing muscle twitches, cramps, paresthesia, and late we're seeing profound weakness, ascending flaccid paralysis in arms and legs become affected when potassium levels become lethal. Okay, so again, we're seeing those paresthesias, we're seeing loss of the tactile discrimination, we're seeing muscle weaknesses, and we're seeing deep tendon hypoflexia and flaccid paralysis of arms and legs. So those are all pretty similar. The one thing that really sticks out to me is muscle twitches and cramps for early signs of hyperkalemia. So I would definitely memorize that. That's something different. And because it's so specific, the deep tendon hypoflexia, although that is similar to the muscle weakness and flaccid paralysis and things like that, because it's so specific, I would also memorize this for the hypokalemia. So let's keep moving on. So gastrointestinally, for hypokalemia, we're going to see decreased motility, hypoactive bowel sounds, nausea, vomiting, constipation, abdominal distension, and paralytic ileus. Now, if we look over gastrointestinally for hyperkalemia, we're seeing increased motility, hyperactive bowel sounds, and diarrhea. Okay, so here we go. Here is big difference number one. Okay, so we want to memorize those gastrointestinal signs for hypo versus hyper. Now, the thing that makes this nice is that with hyper, everything is increasing. We're having increased motility, hyperactive bowel sounds, and diarrhea. Things are moving. With hypokalemia, things are slowing down. We have the hypoactive, the nausea, the paralytic ileus. So things are really slowing down on this side and they're speeding up over here. Okay. So when we talk about EKG changes, there are some important things to remember here as well. So we can see for hypokalemia, we have shallow, flat, inverted T waves. This is important because it's the opposite of the tall peaked T waves we're going to see in hyperkalemia. So again, the thing that is nice is hyper is going up, hypo is going down. So this is easy to remember. Now we are also going to have a prominent U wave in hypokalemia. So just remember that one as well. And you can remember that in hyperkalemia, we're going to see those flat P waves, a widened QRS, and a prolonged PR interval. So you want to definitely remember those EKG changes. So let's talk about risk factors. So anything that is hypokalemia is a potassium loss. So remember, we're low. Our K is low. So this could be from an inadequate intake. Maybe they're fasting or NPO. It could be potassium moving into the cell from hyperinsulinism or alkalosis. It could be a dilution of serum potassium, maybe from IV therapy with potassium deficient solutions or water intoxication. When we're talking about hyperkalemia, medications like ACE inhibitors, NSAIDs, potassium-sparing diuretics can all increase our potassium. Excessive potassium intake can also increase it. Kidney disease or dialysis with decreased potassium excretion, Addison's disease, tissue damage, acidosis, hyperuricemia, and hypercatabolism. So another thing that really sticks out to me is hyperkalemia, you're going to have acidosis, and hypokalemia, you're going to have alkalosis. So that might be something important to remember, those opposites. Now, see, if you're looking at this whole list and you're trying to memorize each side, it's going to be really hard. It's a lot of information. So what we want to do is pick out the key differences. And it may also be good to memorize that hyperinsulinism is for hypokalemia, or hyperuricemia, and hypercatabolism is for hyperkalemia. All right, so our nursing interventions, we're talking about hypokalemia. We're going to do oral potassium supplements, liquid potassium chloride, potassium retaining diuretics, any of these, whatever the doctor orders. Potassium is never administered by IV push, IM, or subcutaneous routes. IV potassium is always diluted and administered by an infusion device. So make sure you know that if there's ever an answer that's asking you to give potassium IV push, that is wrong. Hyperkalemia, things we're going to do for our nursing interventions is monitor EKG, restrict potassium diet, avoid salt substitutes, discontinue IV or PO potassium, prepare potassium secreting diuretics, prepare client for dialysis. This is going to bother me. Diuretics, okay. Prepare client for dialysis, prepare IV calcium gluconate and IV sodium bicarb. And then just to remember, foods with potassium, because this might be something they ask you on NCLEX. Your patient has hyperkalemia, which food would you not give them? So foods with potassium: avocado, banana, carrots, fish, oranges, potatoes, pork, beef, spinach, and tomatoes. And also just remember that potassium and sodium are the opposite. And when we talk about sodium, you will see that more. The signs and symptoms are reversed. Okay, now let's talk about a sodium imbalance. So we're going to talk about hyponatremia, which is a low sodium, less than 135, and hypernatremia, which is greater than 145. So when we have hyponatremia, we're going to see low specific gravity, and when we have hypernatremia, we're going to see high specific gravity. So let's look at the different signs and symptoms based on different systems within the body. So in the cardiovascular system, we'll talk about hyponatremia first. So if someone is normovolemic, meaning they have a normal amount of blood volume, they'll have a rapid pulse with a normal blood pressure. If they're hypovolemic, meaning that they have a low blood volume, there'll be a thready, weak pulse, hypotension, flat neck veins. And if they're hypervolemic, you'll see a rapid bounding pulse with normal or elevated blood pressure. They're going to have shallow and ineffective breathing, but this will be a late sign. You'll see skeletal muscle weakness and decreased deep tendon reflexes. Central nervous system, you'll have headaches, confusion, seizure, coma, and personality changes. Gastrointestinal, increased motility, increased bowel sounds, nausea, abdominal cramps, and diarrhea. Renal will be increased renal output, and integumentary will be dry mucous membrane. So again, when we are looking at the signs and symptoms between hyponatremia and hypernatremia, what we want to do is pick out the differences, and that's what we want to memorize, because if we get a question on it, they're going to be asking about something that's different. So if we look over at hypernatremia, we can see heart rate and blood pressure will be dependent on vascular volume, so not much to differentiate there. Respiratory, we'll see pulmonary edema if hypervolemic, so that is something different. Granted, it's only if they're hypervolemic, but again, pulmonary edema. Neuromuscular, we'll see muscle twitches, irregular muscle contractions, and then late signs will be muscle weakness and decreased deep tendon reflexes. So we want to remember that if it's an early sign, we're going to see those muscle twitches and muscle contractions. Those are things we're not going to see in hyponatremia. Central nervous system, we're seeing altered cerebral function. Normovolemia or hypovolemia, you might have agitation, confusion, and seizures. Hypervolemia, lethargy, stupor, coma. So again, all of those are very similar to hyponatremia. So there's really no kind of differences to memorize. We can remember that with hyponatremia, we have shallow and ineffective breathing as a late sign. So that's important. Gastrointestinally, we'll have extreme thirst. So that is different. So we want to remember that. And then if we come over to hyponatremia, we can see increased motility, bowel sounds, nausea, abdominal cramps, and diarrhea. So again, this is different. So those GI symptoms are very different. So knowing those. Again, here's a big one to know the difference. So renal, if it's hypernatremia, we're having decreased output, but if it's hyponatremia, we're having increased output. So that might be something you're asked about. And integumentary, dry and flushed skin, dry, sticky mouth and mucous membranes, and edema. So the dryness is the same for both, but the difference is you might see edema. So memorize that. So let's talk about risk factors. So with hyponatremia, your risk factors include increased sodium excretion. This could be from diaphoresis like a high fever, diuretics like loops or thiazides, diarrhea, vomiting, drains, and G-tube suction, and decreased excretion of aldosterone. You can have SIADH, adrenal insufficiency, inadequate sodium intake from fasting or NPO, kidney disease, or heart failure. When it comes to risk factors of hypernatremia, could be increased sodium intake, oral sodium intake, IV fluids with sodium, hypertonic IV solutions, or loss of fluids through fever, diarrhea, diabetes insipidus, excessive sweating, and infection. So important things to know is for diabetes insipidus, you're going to see the hypernatremia, and for SIADH, you'll see the hyponatremia, as well as adrenal insufficiency and kidney disease. And also knowing increased sodium intake is going to give you hypernatremia, which would make sense because it's too high. And increased sodium excretion is going to give you hyponatremia because it's too low. So what are our nursing interventions? For hyponatremia, we're going to administer IV sodium chloride. We'll give diuretics if it's due to hypervolemia, because remember, there's too much fluid in the vascular system. It's diluting the blood essentially and making you hyponatremic. So that's why if we give diuretics, we can get rid of some of that fluid and come back to a normal amount of sodium. Daily weight, safety, orthostatic hypotensions because they're at risk for fall, airway protection, NPO if lethargic, limit water intake if hypervolemic, and teach about foods that contain salt. For hypernatremia, if due to fluid loss, we'll administer IV, because if you're losing fluid, that means that there's an increased amount of sodium in your blood because there's less fluid. If due to inadequate renal excretion, give diuretics that increase sodium loss and restrict sodium and fluid intake per order. Foods with sodium are bacon, butter, canned food, cheese, milk, condiments, salt, and bread. And potassium and sodium are opposites. So usually when our potassium is high, our sodium is going to be low, and vice versa. All right, so let's talk about calcium imbalances. So we have hypocalcemia, which is less than 9, and hypercalcemia, which is greater than 11. And the way I remember these numbers is when I think calcium, I think call, and call 911. So that's how I remember that. But so signs and symptoms. So again, we're looking for differences. So for hypocalcemia, we're seeing a decreased heart rate, decreased blood pressure, and decreased peripheral pulses. So this right here, decreased heart rate, that is a key point, because if we come over to hypercalcemia, we can see that there's an increased heart rate at first, and then it does turn into bradycardia. When we look at calcemia, we're seeing decreased peripheral pulses, but when we look at hypercalcemia, we're seeing bounding. Now let's talk about neuromuscular. So for hypocalcemia, we're seeing irritable skeletal muscles, twitching, cramps, tetany, and seizures. So this is a big thing, because if we look over at hypercalcemia, we're seeing profound muscle weakness, decreased deep tendon reflexes. So again, they're the opposite. Hypocalcemia, we're going to have painful muscle spasms in calves or feet during periods of inactivity, paresthesia followed by numbness, may affect the lips, nose, ears, and limbs, increased deep tendon reflexes, anxiety, irritability. So these neuromuscular signs are really important to know because they're different. When it comes to gastrointestinal, same thing, very important to know because they're the opposite. With hypocalcemia, we're seeing increased motility, bowel sounds, abdominal cramps, diarrhea. With hypercalcemia, we're seeing decreased motility and bowel sounds. So this is important, and the big thing to know is that there's something called Trousseau's and Chauvet-Stokes sign. For hypocalcemia, because everything is going up, increased deep tendon reflexes, increased motility, increased bowel sounds, twitches, cramps, tetany, seizures, all of that increase of those symptoms is going to give you something called a positive Trousseau sign, which is a carpal spasm induced by inflating a blood pressure cuff above the systolic pressure for a few minutes. So you put a cuff on the patient's arm, you pump it up, and they're going to have a carpal spasm of their leg. A positive Chvostek sign is contraction of the facial muscle in response to a light tap over the facial nerve in front of the ear. So that is important to know. EKG changes we're going to see. So for hypocalcemia, we can see prolonged ST interval and prolonged QT interval. For hypercalcemia, we see a shortened ST segment and a widened T wave. Risk factors for hypocalcemia include inhibition of calcium absorption in the GI tract, increased calcium excretion through wound drain, diarrhea, steatorrhea, kidney disease, if they're in the diuretic phase, and conditions that decrease the ionized fraction of calcium. For hypercalcemia, our risk factors include increased calcium absorption, decreased calcium excretion, kidney disease, thiazide diuretics, hyperparathyroidism and hyperthyroidism, malignancy leading to bone destruction from tumors, and hemoconcentration. Our nursing interventions for hypocalcemia are to give calcium supplements, either PO or IV, administer vitamin D and aluminum hydroxide, initiate seizure precautions, and consume foods high in calcium. Our nursing interventions for hypercalcemia are to DC the thiazide diuretics or IV PO calcium, EKGs and neurostatus monitoring, loop diuretics, encourage fluids, and restrict dietary calcium. And a patient with a calcium imbalance is at risk for fractures, so move the client carefully and assist with ambulation. Foods with calcium include cheese, milk, spinach, yogurt, tofu, sardines, and greens. And calcium and phosphate are opposites, so if calcium is high, phosphate will be low. Okay, so let's talk about magnesium imbalance. So we have hypomagnesemia, which is less than 1.3, and we have hypermagnesemia, which is 10.5 or higher. So again, we're looking for differences. So for hypomagnesemia, we look at the cardiovascular. So this is important because we have tachycardia and hypertension. When we go over to hypermagnesemia, we have bradycardia and hypotension. So they're opposites. So that's important to know. Now, if we look at respiratory, for hypomagnesemia, we have shallow respirations. And for hypermagnesemia, we have respiratory insufficiency when the skeletal muscles of respirations are involved. Okay, not many differences. When we go back to hypomagnesemia, we're seeing neuromuscularly twitches, paresthesias, positive Trousseau's and Chvostek sign, hyperreflexivia, tetany, and seizures. So these are all important because these are different than hypermagnesemia, which is going to have diminished or absent deep tendon reflexes and skeletal muscle weakness. In the central nervous system of hypomagnesemia, we're seeing increased motility and hyperactive bowel sounds and abdominal cramps. So this is the GI system. So this is important to know because, again, it's something different. Important fact is calcium gluconate is the antidote for a magnesium overdose. So when we look at EKG changes, we can see tall T waves and depressed ST segments for hypomagnesemia. And for hypermagnesemia, we can see shortened T waves and shortened ST segments and a widened T wave. If you don't need to memorize the EKG changes, most likely you won't be asked about that, but you will be asked about signs and symptoms. Risk factors for hypomagnesemia is insufficient magnesium intake. They could be malnourished, have celiac or Crohn's disease, vomiting or diarrhea, increased magnesium excretion through diuretics, alcoholism, hyperglycemia and insulin administration, or sepsis. For hypermagnesemia, they can have increased magnesium intake from antacids or IV magnesium. They can be in DKA or have renal insufficiency, so they have decreased excretion of magnesium. Our nursing interventions for hypomagnesemia is magnesium sulfate IV or PO, seizure precautions, and increasing magnesium-containing foods, which are avocado, leafy greens, milk, wheat, peanut butter, pork, beef, chicken, potatoes, and yogurt. For hypermagnesemia, we're going to give diuretics, IV administration of calcium gluconate because we know that's the antidote, restrict intake of magnesium-containing foods, avoid laxatives or antacids that contain magnesium, and hemodialysis. And magnesium and calcium are the same. So when we have a high calcium, we also have a high magnesium. All right, let's talk about a phosphorus imbalance. So we have hypophosphatemia, which is less than 2.5, and we have hyperphosphatemia, which is greater than 4.5. Again, we're looking for differences. So cardiovascularly, hypophosphatemia will see decreased contractility and cardiac output with slowed peripheral pulses. For hyperphosphatemia, we'll see an increased heart rate early, but then it will turn to bradycardia that can cause cardiac arrest, and we'll have a bounding full peripheral pulse. So that is a difference. We can remember that. With respiratory hypophosphatemia and hyperphosphatemia, both have shallow respirations and ineffective respirations, so not much different there. When it comes neuromuscularly, again, we're not seeing huge differences. Rhabdomyolysis in hypophosphatemia, but they're both kind of showing absent or diminished deep tendon reflexes, weakness, so not much there to remember. But we will see in hypophosphatemia those central nervous system changes like irritability, confusion, and seizures, so that's important to know. And then in hyperphosphatemia, we'll see some gastrointestinal signs of decreased motility and hyperactive bowel sounds. Risk factors for hypophosphatemia are glucose administration or insulin release, respiratory alkalosis, malabsorption syndrome, diarrhea, vomiting, aldosteronism, and diuretic therapy. And risk factors for hyperphosphatemia are renal disease, hypoparathyroid or hyperthyroidism, excessive vitamin D intake, muscle necrosis, excessive phosphate intake, and chemotherapy. Nursing interventions for hypophosphatemia are neurological assessments and phosphate supplements as prescribed. And for hyperphosphatemia, assess for signs of hypocalcemia, teach patients to avoid foods and medications with phosphorus, administer phosphorus-binding antacids, and prepare patient for possible dialysis. Foods with phosphorus include fish, pumpkin, nuts, pork, beef, chicken, whole grains, and dairy. And calcium and phosphate are opposite. So if we have high calcium, we'll usually have a low phosphate. We just went over in depth with the free electrolyte study guide, but within this study guide, you have a more briefer overview of the main points of electrolytes. I'm not going to go through all this again. I included the electrolyte, but this is here in a less colorful form, so you can review these. And again, making sure to know what foods these are in. So let's talk about electrolyte relationships. So sodium and potassium have an inverse relationship. So a high sodium means that you're going to have a low potassium. Calcium and phosphorus have an inverse relationship. So a high calcium is a low phosphorus, and magnesium and phosphorus have an inverse relationship. So low magnesium, high phosphorus. Calcium and vitamin D are the same. So a high calcium means a high vitamin D. Magnesium and calcium are the same. So a low magnesium, you're also going to see a low calcium. And magnesium and potassium are the same. So a low magnesium can also mean a low potassium. Okay, let's talk about acid-base balance. So we have two different manifestations. So we have acidosis and alkalosis. Now, within each manifestation, it can be respiratory or metabolic. It can be respiratory or metabolic. So these are the signs and symptoms we're going to see. So first, let's talk about acidosis. If it's a respiratory acidosis, we're going to see drowsiness, disoriented, dizzy, headache, or coma. And if it's a metabolic acidosis, we're also going to see drowsiness, confusion, headache, and coma. If we come over to alkalosis, for neurological, lethargy, lightheadedness, confusion, metabolic, drowsiness, dizziness, nausea, confusion. So all of these are very similar. So you don't need to go through each one and remember respiratory, I'm going to see this for acidosis. Metabolic, I'm going to see this for acidosis, because you're really seeing the same thing for almost all of these. We want to look at the differences. So one thing I see is metabolic alkalosis, nervousness. So that might be a key thing to remember. I'm also seeing that for acidosis, we may see a headache for both metabolic or respiratory. So that might be something to just remember. But now let's move down. So cardiovascularly, for respiratory acidosis, we're seeing decreased blood pressure, dysrhythmias, warm flushed skin. For acidosis metabolic, we're seeing decreased blood pressure, dysrhythmias, warm flushed skin. Again, same symptoms. So, okay, we don't have to really remember the differences with those. If we come over to alkalosis and we look at respiratory alkalosis, we're seeing tachycardia, dysrhythmias. For metabolic alkalosis, we're seeing tachycardia and dysrhythmias. Okay, so we can see with this one that how we can differentiate it is with acidosis, we're seeing a decreased blood pressure and dysrhythmias. So the main thing is the decreased blood pressure for acidosis. Both. It could be either, right? This isn't differentiating between respiratory and metabolic, but we're seeing decreased blood pressure. When it comes to alkalosis, the real difference that we're seeing is the tachycardia, and we could see that for metabolic or respiratory. So let's just remember that. Okay, so let's move along. So for respiratory acidosis, we're seeing no GI symptoms. For metabolic acidosis, we're seeing nausea, vomiting, and diarrhea. Okay, so that's important to know that those are some differences. Now, when it comes to gastrointestinal for respiratory alkalosis, we're seeing nausea and epigastric pain. When it comes to metabolic alkalosis, we're seeing anorexia, nausea, and vomiting. So this is supposed to say vomiting. Okay, there we go. I will fix that in the study guide. We can see that the difference, a key thing is with respiratory alkalosis, epigastric pain. Okay, so let's remember that, epigastric pain. Okay, so now let's move along to respiratory acidosis. So we're going to see neuromuscular, we're going to see seizures. That's important, so remember that. And then for metabolic acidosis, we have no neuromuscular symptoms. For respiratory alkalosis, we're seeing tetany, numbness, tingling of extremities, hyperreflexia, and seizures. So we need to remember all of these, right? Tetany, numbness and tingling, hyperreflexia. So this one is a key for respiratory alkalosis specifically, right? We don't see that for any of the other ones. And again, if we come over to alkalosis metabolic, we again have those tremors, hypertonic muscles, muscle cramps, tetany, tingling, seizures. So these are the same. So just noticing that alkalosis, you're having a lot of those neuromuscular symptoms. All right, so moving along, respiratory acidosis for respiratory is going to be hypoventilation with hypoxia. Very important. This is different than our metabolic acidosis, which is going to have deep, rapid respirations or Kussmaul's. So these are different. So remember those. For alkalosis respiratory, we're having hyperventilation. Again, this is different. So remember this one. And for metabolic alkalosis, we're seeing hypoventilation. So you want to remember all the differences in respiratory. For these, you can see a significant difference. For respiratory acidosis, the causes are asthma, electrolysis, brain trauma, central nervous system depression, pulmonary edema, COPD, and hypoventilation. For metabolic acidosis, our causes are diabetes, excessive ingestion of acetylsalicylic acid, high-fat diet, malnutrition, and diarrhea. For respiratory alkalosis, our causes are fever, hypoxia, hyperventilation, pain, and hysteria. And for metabolic alkalosis, our causes are diuretics, vomiting, hyperaldosteronism, ingestion of sodium bicarb, and a massive transfusion of blood. Our nursing interventions for respiratory acidosis are monitor signs of respiratory distress, administer oxygen, place them in semi-Fowlers, turn cough, deep breathe, and hydrate to thin secretions. For metabolic acidosis, our nursing interventions include monitor for respiratory distress, assess level of consciousness, monitor INO, monitor potassium, and if in diabetic ketoacidosis, give insulin. For respiratory alkalosis, our nursing interventions are to monitor for signs of respiratory depression, emotional support, assist with breathing techniques, and monitor electrolytes. And our nursing interventions for metabolic alkalosis are monitor signs of respiratory distress, monitor ABGs, potassium and calcium, IV medications, and replace potassium. All right. Now let's talk about interpreting arterial blood gas results. So key points. In acidosis, the pH is decreased less than 7.35. In alkalosis, the pH is elevated, greater than 7.45. Respiratory function indicator is the CO2, and a metabolic indicator is the HCO3. Okay, so important to note that we know that a normal pH is 7.35 to 7.45. So if we go below that, we're in acidosis, and if we go above that, we're in alkalosis. Okay, so again, here's our normal values over on the right side for all of these. The thing that's nice is our pH is 7.35 to 7.45, and our CO2 is 35 to 45, so it's the same. HCO3 is 24 to 26, so you do have to remember that. And our PaO2 is 80 to 100%, we know that. And our SaO2 is greater than 95. Okay, so let's talk about the steps to interpret arterial blood gases. So step 1, we're going to look at the pH. So this is step 1. Is it high or low? And again, we just talked about if it's low, it's acidosis. If it's high, it's alkalosis. Okay, step 2, look at the CO2. Is it high or low? What is the relationship to pH? So opposite relationship, one is high and the other is low, means a respiratory imbalance. A same relationship, both high or both low, go to step 3. So a way to remember this is something called ROME. And this stands for respiratory, opposite, metabolic, equal. Okay, so if it's opposite, it's respiratory. If it's the same, we're going to go on to step 3. Most likely metabolic, but there is a thing that it is not always metabolic. All right, so we're going to look at the HCO3 and what the relationship is to the pH. So if it's the same, both low or both high, it's a metabolic imbalance. All right, so let's move on to step 4. So if the pH is normal, but other things are not normal, it could be due to something called compensation. And that means that the body adjusts and compensates with other things to make the pH normal. So partially compensated is if the pH is not normal, we look at the system that is supposed to fix the problem. So if the condition is a respiratory imbalance, look at the state of HCO3 to determine the state of compensation. If the condition is a metabolic imbalance, look at PaCO2 to determine the state of compensation. What this means in a equation format is that a low pH plus a high CO2, respiratory acidosis, because we have a low pH, we know it's acidosis, and we have a high CO2, so we know that it's respiratory. A low pH plus a low HCO3 is metabolic acidosis. So again, we are looking at, because we know that if we follow Rome, respiratory opposite, so we can see low and high is opposite, and then a low and low is equal, so metabolic equal, so we have a metabolic acidosis. If we have a high pH and a low CO2, we're opposite, right? Low and high, so we know it's respiratory alkalosis, and a high pH plus a high HCO3, we know metabolic equal, So we know metabolic is equal, so it's metabolic alkalosis. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com.